Thank you for being here. First, let me highlight something, Dr. Adams, that HHS has done. Y'all had a task force on pain management, which was really good, because your statement earlier said that there's still untreated pain, and yet we have people who are dying from addiction. That is the tension. And as you know, Dr. Vanilla Singh headed this up, but they differentiated between the patient with chronic pain on stable dose for many years, never escalating, working in society, from the person who's breaking into a car to steal a purse to buy drugs. And so that's a distinction we have to make as a physician. Let's not turn our backs, if you will, on the person who has that stable dose, who's contributing to society, which includes people in this room, and differentiate that person from those. Secondly, to my two GAO folks in the middle, y'all been kind of ignored, but I've been thinking about you. I hear that private insurance companies are very capable at looking at pain management, looking longitudinally at the outcomes, okay, who is released and then immediately goes back into a situation requiring more care for addiction versus those who have a sustained response. And yet we continue to hear that Medicaid does a poor job of that. Now, it seems like this would be something that could be done with a supercomputer in terms of, if you look at diagnostic codes, okay, if somebody has a billing for admission to a pain management center, and then they have a readmission for something which plausibly is related to drugs overdose within a period of time, and you compare everybody against everybody, and you sort out who's doing a good job, who could perhaps employ science-based methods and improve their work, and who should just be kicked out. Now, what is the obstacle to doing so? Either of you.
I'll start from OIG's perspective. We do a lot of analysis similar to what you just described in the Medicare space. We have great access to Medicare claims data. But on the Medicaid side, we don't have that same level of quality.
So let me ask,
data.
So we do have the Transform Medicaid Statistical Information System, or TMSIS. Is TMSIS not ready for prime time?
Not quite ready for prime time. Improving, but not quite ready for prime time.
But it's rapidly improving, which makes me think that some states are ahead of the curve, some states perhaps still coming on. I think I know that 48 are currently participating, obviously do not. So can we take those as proof of concept that are already submitting adequate data and then creating a system which scales as other states come on board?
That's something we could explore.
Now, why not something we do?
Well, sir, I work for the investigations office, so I don't want to commit our auditors and our evaluators yet, but it's something we're very interested in. I'll take it back and we can follow up with you.
Okay. Ma'am?
So similarly, the work that we have done that I'm familiar with would be related to Medicare because the data is there, and we have previously reported.
By the way, can I insert one thing? I've actually spoken to people who work for clearinghouses. And so when somebody changes a Medicaid plan, they have to do data. And these clearinghouses are actually better than TMSIS because they got it all. And it has to be with a unique identifier because it's transmitting, Bill Cassidy's claims data from plan A to plan B. And so these folks actually have it, just to point that out as a point of information.
So as GAO, we actually work for you, and we would welcome a conversation to have a discussion about work that we can do in this area for you.
Now, let me ask you one more time, because GAO always does a wonderful job, but roughly in the time it takes you to complete a study, an elephant is born. So it takes a little while. We actually need something real time. So Dr. Adams, is it possible for HHS to stand up something real time that's doing this analysis, maybe getting a system from one of these two folk, but that which you can employ, so that we don't have to wait for a year and a half for an excellent study, but by that time, situation on the ground perhaps has changed?
Well, that's definitely something I'll take back, and you know, sir, that I will follow up with you. I appreciate your leadership as one of the few physicians in Congress, and I think you bring up a very important question and issue.
Let me ask you one more thing. I've done a lot of work in jails. You mentioned your brother, and thank you for your openness about that. And I think the statistic I read is that 15% of males entering a jail have a mental health issue, 30% of females. If you add addiction to that, you're going to be even higher. Current law is that if you are jailed even before you are adjudicated, you lose your VA and Medicaid benefits. Okay, so I've been arrested, but I am not, I got 3 months, sometimes you spend 6 months in jail before you go to court. And I'm mentally ill, but I've lost my benefits, even though subsequently I'm declared to be not guilty, right? And this is a fairly common scenario. I'm not making things up. There is a score associated with this. But as a physician, I know that if the formulary in the jail does not include the psychotropics, which have stabilized me on Medicaid out in the free world, that my care becomes disrupted and my condition may decline. So I'm begging the question, but can you give your thoughts, and maybe I can kick it over to you, sir, as to the whatever the score, the wisdom of allowing Medicaid and VA benefits to continue with someone who's incarcerated in a jail, at least prior to the point of being declared guilty or not guilty.
So you bring up two important points. Number one, our jails and prisons have become our de facto mental health and substance use disorder providers in this country, and we need to flip that script if we're going to dig our way out of this. And number two, when I saw this firsthand in Scott County, we actually had to work very closely with the jails to solve our HIV outbreak that was related to prescription opioid misuse, because we know that so many folks would cycle on, cycle off, cycle on, cycle off. It is a significant problem.
So what you're telling me is that they would be admitted for HIV and their regimen would be disrupted, so they'd develop resistance because they're getting off the one that controlled it and whatever strain was there, et cetera, right?
It's certainly not optimal for care, sir, and we need to look at how we can transition that system. But I will also say just very plainly and frankly to you, sir, that I learned in Indiana that we didn't have a lot of flexibility at the state level. Some of that is because of the law as written currently. And so we need to take a look at that. We need to take care of the person and the patient because it has implications beyond that individual and on society.
Well, I'm glad Senator Brown is here from Ohio because I'm going to need a bipartisan colleague. I think the score is $10 billion over 10 years to allow those Medicaid benefits to continue when someone is, as I've described, put in jail, but before they are adjudicated. Sir.
Thank you. I'd like to add something. Throughout the last hour, we've talked about different components of the opiate epidemic and solutions. And as we've talked about each, we've talked about how to remedy each of these individually. But I think it would be really helpful if we could go back to the Surgeon General Adams has mentioned 3 times in the last hour something else that I don't think it's gotten the airtime here, which is stigma, which the Surgeon General has called the biggest killer out there. He hasn't talked about any of these specific issues being the biggest killer. It's stigma. And why has he said that? He said that because stigma reaches everything we've been talking about for the last hour. If there's policies in jails where people lose their insurance, why is that? That's because most people in America think that it's bad people doing bad things who can't make good decisions, when science shows that's not the case. It's why aren't payment policies equal to other physical diseases? Because we've grown up in a healthcare industry that believes it's their fault. We shouldn't pay for treatment. 20% of doctors in this country have, in the state of Massachusetts, in a recent study that we did, which I suspect is relative to the rest of the country, don't want people who are addicted in their waiting rooms. It might affect their practice. 80% of Americans in a recent poll, 80% of Americans in a recent poll said, I am uncomfortable associating with someone addicted to prescription opioids as my friend, my coworker, or my neighbor. So let's say we get through all the hurdles we've been talking about in the last hour, and someone gets to treatment, even though 20% of Americans have reported one of the key reasons they don't go to treatment is they don't want anybody to know. But let's say they get past that hurdle, and their parents force them in. They get to treatment. And then they find a provider, even though there's very few providers that treat it today for the reasons we've been talking about. And then they get to a provider who delivers quality care through all the hurdles we've heard about today. And they're successfully treated. But then they enter a society where 80% of Americans don't want you working next to them, don't want you living in their neighborhood, don't want to be their friend, don't want you marrying their daughter or dating their daughter. I'm sure my son didn't see those statistics, nor the 20 million Americans. This is not just opioids. The 20 million Americans who are addicted to drugs or alcohol see that survey, but they feel it. They feel it every day.
So I thank you and Dr. Adams for being so honest with your experience, because that helps fight that stigma. Senator Brown.